Hey guys, welcome back. This is the second week of online instruction. This is your second week video, week of March 30th for EMS 160, and the topic is cardiac arrest management. So believe it or not, even though cardiac arrest is obviously a high acuity call, it's a high stress level call for all of those involved. Don't forget your family on scene and first responders and things along those lines. But it is actually a fairly straightforward call to run, a very straightforward patient to treat. There's really only two protocols per se that we're going to utilize in cardiac arrest management for just working the code. Next week we're going to talk about post cardiac arrest management. We'll add in a few things, but it's still not super complicated. So let's get down to business. So first we're looking at the cardiac arrest adult protocol. This is your state protocol number AC3, and we are going to focus on your state protocols because your text does a good job of giving a lot of background information, but it doesn't do a very good job, in my opinion, of laying out exactly what to do, and exactly what to do is going to be more important here. So the first rule of cardiac arrest management is that everybody at some point in their life is going to die, and the fact that they have died is not your fault. Okay, so I know that that may seem silly, but when you can put it into perspective in those terms, then it makes it a little bit easier for you to deal with this call when it arises, because you are going to run codes. You are going to be the very last person that someone speaks to or sees on the face of this earth. It's just going to happen. That's part of this job. That is something that can obviously affect you emotionally, but we have to be able to perform our job, right? So if you remember that this isn't my emergency per se, I don't necessarily like that term, but it really is true. You have to be able to focus, and you have to be able to provide patient care as adequately as possible without getting the emotions involved. So first things first, most of the time when cardiac arrest happens in the pre-hospital setting, we are way behind the 8 ball. And what I mean by that is that survival rates are extraordinarily low for out-of-hospital cardiac arrest. And one of the large contributing factors to that is because we don't have early CPR and early defibrillation. If you compare out-of-hospital cardiac arrests, survival rate to in-hospital cardiac arrest survival rate, in-hospital is drastically higher. There are a lot of factors that play into that, but one of the biggest factors is normally in the hospital, and should be all the time in the hospital, when cardiac arrest occurs, there's someone immediately available to provide interventions. Whereas we may have a 10, 15, 20, 30-minute response time. It just depends on where you are, what county you're working for, how many ambulances you have for that county, the area you're having to cover, so on and so forth. There's a lot of factors that go into response time. But if you remember back in your textbook, back in, I guess, the first or second week of 160, we talked about the amount of time that surpasses from when the patient stops breathing or when the oxygen levels in the body start to drop, really, until you have permanent irreversible brain damage. And if you remember, it's 5 to 6 minutes. So 5 to 6 minutes from the time that the brain starts becoming hypoxic, you will have permanent irreversible brain damage. Now, the extent of that brain damage could be subjective, but regardless, brain damage is occurring. How many times do you think the person collapses in cardiac arrest and you are on scene and ventilating this patient and providing good quality chest compressions within 5 to 6 minutes? Probably never. If you are, then I want to know where you're working, but it doesn't happen very often. Bystander CPR is not a super common thing, unfortunately. The American Heart Association a few years ago, 2010, ECC guidelines introduced CCR, which is cardiocerebral resuscitation, versus CPR. This is also known as hands-only CPR. And one of the big reasons that they introduced that was to encourage bystanders to perform chest compressions on cardiac arrest patients. What they were finding is that people were unwilling to do chest compressions because they thought they had to put their mouth on somebody, and obviously that's not a desirable thing. So if we can just push on the chest before EMS gets there and keep blood circulating to the brain, to the heart, to the lung tissue, then we're going to be able to extend the period of time that that patient can go without their heart pumping on their own and or not breathing on their own. So back to topic here. We're going to look at our protocol. Again, this is AC3. This is your general overview cardiac arrest for an adult. Pediatric protocol is a little bit different. We're not focusing on that this week. Pediatric will be in another semester. So, very first thing that you should think of when a cardiac arrest patient is presented to you is the criteria for death met? What is the criteria for death? Criteria for death in North Carolina is decompensation, rigor mortis, dependent lividity, blunt force trauma, with an injury incompatible with life, or any injury incompatible with life. It could be penetrating as well. Blunt force, we'll look at that a little bit later, but blunt force trauma, your state protocol now says that if your patient is in asystole or PEA due to blunt force trauma, that we shouldn't even work the call. Okay, shouldn't even work the code. So any injury incompatible with life, maybe the patient was decapitated, maybe they were, I don't know, some injury that's incompatible with life. Obviously, no matter what you do, they're not going to make it, even if you had a surgeon on scene here. That's what injury incompatible with life means. And then extended downtime with asystole. So that's subjective as well. What is extended downtime? Your protocol is you're looking somewhere 15 to 20 minutes. Okay, 15 to 20 minutes. If we meet all of those things, and that 15 to 20 minutes is not definite per se, but that's normally what we consider extended. So if we meet any of these criteria for death, then we're not going to begin resuscitation. Okay, that means I'm not going to do CPR. Another thing to think about that's not listed on here is cold in a warm environment. Cold in a warm environment. If your patient has rigor mortis, but they're still warm because they were laying in a blanket with a heating pad, that's not really the same. Right? So temperature isn't a huge factor in determining should we work it, should we not work it, with the exception of your patient is really cold in a warm environment. It takes quite a while for the body temperature to decrease that drastically. That would be another thought to consider. Okay? But when we're documenting why did we not work this code, these are the things that we're looking for right here. All right. So, was criteria for death met? We're going to say no. No. Was there a resuscitation review DNR, meaning was there a DNR or a most form present? Remember that DNR means do not resuscitate. It doesn't mean do not treat. If your patient's in respiratory distress with a low blood pressure, you can still give IV fluids and get an albuterol neb or whatever you need to do for this patient, okay? DNR means do not resuscitate. So when their heart stops, I'm not going to pump on their chest. I'm not going to intubate and give medications and things along those lines. The most form is specific to North Carolina, and it stands for Medical Order Scope of Treatment, MOST, Medical Order Scope of Treatment. If you're not already familiar with the most form, I will put a copy of it on your Blackboard this week so you can take a look at it. Basically, the most form breaks it down in a little bit more detail. So it doesn't just say do not resuscitate. It may say, hey, you know what? I want an IV. I do want IV fluids, but I don't want antibiotics. Or maybe I don't want this for more than a week. Or maybe I want supplemental oxygen, but I don't want to be intubated. So on and so forth. It's a fairly descriptive document that kind of took the place of a living will in North Carolina a few years ago. Excuse me. And make sure that we're taking a look at that because there is a DNR box on the most form to be checked. So both of those are legal documents in the state of North Carolina. Obviously, if there's ever a question of whether you should work somebody or whether you should not work somebody, the answer is always work them. If there's ever a question, act in the patient's best interest, you're always going to come out on top. All right, so we're going to say there's no DNR, there's no most form, and there is no obvious criteria for death. So very first thing we're going to do is start compressions. Notice ventilation isn't first, IV isn't first, intubation isn't first, medications are not first, CPR. Chest compressions are first. So there are only 2 interventions that are considered a Class 1 intervention by the American Heart Association. And Class 1 means that there is ample evidence to support their use. Only 1. So we'll break that down more in a little while and I'll show you how amazing that is. Okay, with all the stuff we're going to talk about, there's only 2 things, I said one a second ago, only 2 things that are that Category 1, Class 1. And those are chest compressions and defibrillation. Those are the only 2 things that have been actually proven effective in the management of cardiac arrest. We provide all kinds of other interventions with hopes that it's going to help, and there's some limited evidence to support their use. We're not just randomly pulling stuff out of a bag and saying, oh, well, maybe this will help. There is some evidence to support the use most of the time with the interventions that we're using, but the only 2 things that have unwavering, well-documented evidence are CPR and defibrillation. So the very, very, very first thing that you should do is start chest compressions. So remember that chest compressions for an adult are at a rate of between 100 and 120 compressions per minute. The depth should be greater than or equal to 2 inches, or we could also say 1/3 the AP diameter, which is anterior-posterior diameter, which means we're going to push at 1/3 the depth of the chest, just a fancy way of saying depth of the chest. We're going to push fast. We already said that 100 to 120, and we're going to make sure that we change compressors every 2 minutes or sooner if your compressor is fatigued. when you went through CPR class last semester, then I made you do a few minutes of CPR. The purpose of that was to see how quickly you get fatigued. And those mannequins are nothing in comparison to a grown adult. It's very tiresome to do chest compressions, especially for an extended period of time. So make sure that when you begin to get fatigued that you say something so that you can swap out. That doesn't mean that you're not doing your part. It means you're doing a better job for that patient, because when you get tired, you do not do adequate compressions. All right, so at least 2 inches, 100 to 120, change compressors every 2 minutes. And for an adult, if it's 1 rescuer or 2 rescuer, which of course on the ambulance we're always at least 2 rescuer, but just for reference, 1 rescuer or 2 rescuer, your compression to breath ratio is always going to be 30 compressions to 2 breaths. 30 compressions to 2 breaths. The only exception to that rule is if you have an advanced airway in place. So once the patient is intubated, or in this case a king airway, an iGel, a combi tube technically would count for this. Once you have some type of actual tube that is in theory somehow isolating the trachea or close to isolating the trachea, then we're going to stop our 30 to 2 and we're going to ventilate 1 breath every 6 seconds with continuous CPR. So we're not going to stop chest compressions to deliver breaths anymore. We're going to continue on CPR and we're going to give 1 breath every 6 seconds once an advanced airway is in place. All right, continuing on. Excuse me. All right, so is ALS available? Obviously, yes, because we are ALS. So we're going to focus on the right side of this protocol. Yes, the first thing that it recommends is cardiac monitor. Why do you think that comes next? Well, the reason that comes next and the reason that it's on the same line in the protocol as the AED procedure is because we no longer use an AED as ALS providers. We now interpret the rhythm manually. So there are 4 rhythms that we typically talk about with cardiac arrest management, and that's asystole, that's PEA, that's ventricular tachycardia, and ventricular fibrillation. I'll make another video that outlines each of those, okay? So don't worry about that. So we do know, and we should have learned last semester, that there are only 2 shockable rhythms, and those are VTAC and VFib. So this says VF, VT, that's VFib, and VTAC. And remember, this is pulseless VTAC because we have talked about previously VTAC that the patient can have a pulse. So once the patient no longer has a pulse with their VTAC, they're considered to be in cardiac arrest. Asystole, PEA, it's very important to understand that PEA does not mean that the heart is not beating and or that there's not some type of electrical activity. There's obviously electrical activity with PEA because it's pulseless electrical activity. I see a rhythm, but I don't have a pulse. Again, I'll do in more detail on that in just a few minutes in another video, but it's important to know that just because I cannot feel a pulse does not mean that the heart may not be contracting to some extent. Let's say you take a blood pressure in your patient's arm, your patient's semi-responsive, and their blood pressure is 68/42. And you wait 5 minutes, the patient's unconscious now, and you try to take a blood pressure and you can't find one. What if the blood pressure dropped down to like 40/20? Do you think you'd be able to feel a pulse with that? Probably not. Probably aren't going to feel a central pulse with that either. If you can't feel a pulse because the blood pressure is so low, then your patient technically meets criteria for cardiac arrest. We don't know why we're not feeling a pulse, okay? But it is important to understand that PEA doesn't mean that there is electrical activity and the heart is just not functioning because of it or in spite of it. That could be the case. You could have electrical activity in the heart and then the muscle fibers are just not contracting for whatever reason. Much more likely cause, though, is that the blood pressure is just so low that I cannot feel a pulse. We're going to treat this in the exact same way, and that's kind of a pet peeve of mine that we'll talk about in a couple of semesters because I think there's a lot of things that we can and should be doing differently for the management of PEA because in most situations there is still some sort of cardiac contraction, organized cardiac contraction with PEA. But we will talk more about that. So either asystole or PEA or VTAC or VFib. These are the 2 algorithms that we can follow for cardiac arrest management. We're going to go one of 2 ways. Okay, asystole, PEA are treated exactly the same. VTAC, VFib in almost every situation are treated exactly the same. So you have 2 routes. That's why I say this is a simple call to run because both protocols are fairly simple and there's only 2 of them. Right, so you have 2 options of what to do. I'm going to treat asystole, PEA, or I'm going to treat VTAC and VFib. Know that VTAC and VFib are the only 2 shockable rhythms in cardiac arrest. Scroll down just a second to our pearls. We're almost out of time for this video. I can only do 15 minutes with the app that I'm using. So we're actually going to pick this up in another video.